Welcome to today's webinar. What do all those lines and colors mean? Interpreting cancer data plots. My name is Janet Freeman Daly, and I'm the moderator for today's program. Next slide. Let's begin by running through the housekeeping rules. If you would like to download today's slides, you can access them on the webinar webpage. A link to it has been posted in the chat. You will be able to find a video recording of this webinar on that same webpage within the next week. All participants were sent an email with instructions for accessing the live interpretation audio. To find those instructions, use the link in the chat to access the webinar page and click on Live Interpretation Instructions. The instructions will also be partially posted in the chat. If you have problems, use the chat to contact support. Now, note, we have not done a webinar in multiple languages before. We ask that you, when you post your questions, try to post them in English. If you post them in your native language, we will try to interpret them with Google Translate. We will have a question and answer session after the talk has ended. Please enter your questions for the Q&A discussion at any time in the Q&A section at the bottom of the Zoom screen. Your camera and microphone will remain off for this webinar, and we will not be using the raise hand function for questions. You can use the chat for other discussions if you wish. And now I will introduce our speaker. Next slide. Dr. Amy Moore is VP of Global Engagement and Patient Partnerships for Longevity. She holds a PhD in virology from Wake Forest University School of Medicine, was an American Cancer Society postdoctoral fellow at Vanderbilt University Medical Center, and has been in the nonprofit sector for over a decade, first in the state of Georgia, where she worked to build a statewide cancer initiative, and more recently in the lung cancer space. She works closely with biomarker patient groups, spearheads Longevity's growing global efforts, and serves as the organization's lead for all things COVID-19. Welcome, Amy.
Thank you, Janet. It's such a privilege to be here with you today, and thank you to ISLC for the opportunity to lead this session, and I hope it will be informative for everyone and look forward to answering your questions. So next slide, please. So today we have several learning objectives for interpreting cancer data plots. Through this webinar, we hope that you'll be able first to identify the different types of data plots that are commonly used to present cancer clinical trial results. Two, that you'll be able to understand the layout, terminology, and significant data in each type of plot. And finally, that you'll be able to improve your ability to communicate clinical trial results to patients and caregivers, as well as the public at large. So let's get started. Next slide. So I want to start with just giving you a basic orientation to the anatomy of a clinical trial. And here we're looking at a 5-year trial. So once the trial starts, there's an initial startup period of several months, and then the trial opens for enrollment. Now here we have to determine eligibility through various criteria, and we'll look at that more closely in just a moment. The important thing to note here during this accrual period is that patients can enter a trial at any point during that open accrual period. So that means that some patients may enroll at the very beginning, and others may enroll closer to the end of that enrollment period. So we're going to have different amounts of information on patients according to when they actually enrolled in the trial. Now, clinical trials need to enroll a certain number of patients to achieve their endpoints, to answer the questions that they were designed to address, and to achieve what we call statistical significance. Once the trial enrolls that preset or predetermined number of participants, it will close enrollment. At that point, data analysis will begin. So the trial is ongoing, but no more patients can sign up to participate in the trial. So that's the basic anatomy of the trial. Next slide, please. So as I mentioned, patients can enroll in that open accrual period basically at any point. So here we see 3 different patients, patient L, patient S, and patient M, who have all enrolled on the trial, but at different points. Now, each of those patients is going to be followed in serial time. A couple of other things to note is we see closed circles and open circles here. Now, closed circle for patient S indicates an event occurrence, whereas the open circles for both patients L and M indicates that they were censored. This simply means that they were lost to follow-up for whatever reason, but their data can no longer be used to determine survival in the trial. So that's important to note, and we'll see how that matters and how that's reflected in some of the subsequent graphs that we'll be looking at momentarily. So next slide, please. Now, this shows you a typical schema or how a clinical trial is designed. As I mentioned just a moment ago, patients are put on a trial according to their eligibility. So there are various factors that investigators will look at to determine if a patient is eligible to participate in the trial. And that may be by their stage of disease, their particular type of lung cancer, their type of treatment, whether they've been on targeted therapy, immunotherapy, chemotherapy, maybe how many previous lines of treatment they've been on, their performance status. And so all those things are taken into consideration. Now, once you meet those eligibility criteria and are accepted to participate in the trial, then you'll be categorized by the question that's being asked in a particular study. So in this example we have here, once patients are put on trial, they're sorted into two groups, and that's by their relative levels of PD-L1 expression. In this case, looking at people who have low versus maybe people who have higher PD-L1. Now, an important thing to note is that in both phase 1 and phase 2 trials, which are earlier stage, we won't see randomization of patients to additional arms. But in this case, in a phase 3 or phase 4 study, patients will then be randomized to different study arms to look at the various interventions to determine if they have a benefit. So that's an orientation to how trials are designed. Next slide, please. Now, before we get into the plots themselves, we need to understand some basic clinical trial endpoints. Now, an endpoint is just an event or outcome that can be measured objectively to determine if the intervention provides benefit to patients. So the gold standard in cancer clinical trials is overall survival. That's the fourth one on the list here. And that's the time between treatment and patient death. The good news in the lung cancer space is that patients with the arrival of immunotherapy as well as targeted therapy are living much longer. So overall survival can take longer to reach. That's a good thing for patients, but it's challenging when it comes to looking at drugs and whether or not they can be approved. So in that case, we're often looking now at alternate endpoints that can be used for making some of those decisions. And more recently, we've seen a lot of emphasis on progression-free survival. Now, this is the length of time between treatment and measurable worsening of the disease. We can also look at things like disease-free survival. That's the time between treatment and relapse. This one's particularly useful in the context of things like surgery. Another endpoint is response rate. So that's the percentage of patients whose cancer shrinks or disappears after treatment. This one's useful for single arm studies that don't require a control arm. Finally, we also know that quality of life matters when it comes to patients on treatments. And we're seeing growing emphasis on this area in particular. And that basically looks at whether a drug's impact, at the impact of the drug on a patient's pain or other symptoms related to their condition. In this case, we often rely on what we call patient-reported outcomes. So the patients need to tell us what their experience is and how it's impacting, these various issues. So that's a growing area of emphasis and something that even we at Longevity are very interested in understanding and working on through some of our efforts. So with that orientation, let's start delving into some additional things. Next slide, please. So today I'm going to be talking about several different types of plots. We'll go through survival curves, often or also known as Kaplan-Meier curves, forest plots, a little bit about adverse events, waterfall plots, swimmer plots, and spider plots. Now, as we go through each one, I'll tell you what is being represented or what's being addressed by the plot. Next slide, please. Now, there are some basic tips for identifying data plots. I basically compare this to, back before the days of GPS when we were having to, unfold our map in the car. We have to orient ourselves to, what's the map showing us. So let's start by looking at the title. What's the type of study, the method, or the analysis? What's the conclusion? Look at your axis labels. This is, I think, one of the best ways to kind of orient yourself to where you are in looking at these graphs. So find your X and Y axes. So the Y axis is your vertical axis. It's on the left, it goes up and down. Your X axis is the horizontal one that goes across the bottom. And these are going to vary from graph to graph. And so it's very important that you read the labels of these axes because it'll tell you what's being represented. Finally, you want to look for the legend. There's a nice little tool that's often provided on graphs, and it may come in the form of a little box somewhere on it that will tell you what different colors mean, or maybe different shapes that are included and what they mean. So all those things are going to help orient you to what you're looking at. Next slide, please. So we're going to start with a basic orientation to survival curves, also known as Kaplan-Meier curves. And this is the survival over time for the entire group of trial participants. Now, again, as I told you, kind of the first thing you want to do with any of these graphs is to get your bearings, figure out your y-axis and your x-axis. So here on the left, going up and down, our y-axis says survival as a percent. In this case, we're looking at overall survival. At the bottom, you can see time in months. We also see number at risk. So this is the number of participants that remain on the trial. Now you see over time, as we go from left to right, that number decreases. That's because either patients may die, they may experience progression, they may drop out. And so that number does change. Now here on this graph, we have two curves, one in green and one in purple. Now, each time you see those curves drop down, in this case, since we're looking at overall survival, it represents a patient death. But basically, we're comparing two interventions, one which may, and the question being asked in the clinical trials is, does it provide a benefit to patients compared to standard treatment? To begin to ask that, we need to look at what is the median overall survival. So to determine median survival, we want to go to our y-axis on the left, find that 50% mark, and then kind of draw a horizontal line across until it intersects each curve. At that point where it intersects, we're going to drop a vertical line down to the x-axis to look at time in months. Now, in this case, if we do that exercise for the purple curve, we go across and drop our line down, we see that median survival is roughly 9.5 months. By contrast, doing the same thing for the green curve, we see that median survival is 24.5 months. Now, you may also want to know, well, how many patients are still alive at a year into the study? In this case, we would come down to our x-axis, which is time, find that 1 year mark, which in this case is 12 months, and then we would draw a line up until it intersects each curve, and then carry a line across to see what percentage of patients are still alive. When we do that exercise for the purple curve, we see that at 12 months, roughly 34% of the patients are still alive. By contrast, if we do that for the green curve, we see that at 12 months, 69% of the patients are still alive. Now, I told you as we were going through how patients are monitored in serial time, we saw those open circles that meant that patients could be censored. Now, in that case, we would see that indicated as a tick mark on these curves. And you can see on the purple curve at the bottom, the circle indicating a patient who has been censored. Again, that data does not go into informing overall survival for statistical purposes, but it is represented here on the curve. Another thing to note is you can see as we get to the bottom of the purple curve in particular, there's a long tail, which means that the line stays straight. It doesn't continue to drop. So at that point, patients, seem to be kind of plateauing. There's no additional deaths. And so that's something that may also be informative for you as you look at these curves. But another thing that I really want to point out is we have two curves here, and there's a nice separation between the curves. There's a lot of space between them. And that's a good thing because it suggests that, one treatment is clearly better or appears to be better than another. So with that orientation, let's look at a real world example. Next slide, please. So again, there's a lot of information that can help orient you to what you're looking at. And you want to read titles and labels, read your axes, and that will help you understand. Now, in contrast to the last slide I showed you, which was looking at overall survival, this is one looking at progression-free survival, which is another of those endpoints I described. But here we're looking at, again, tumor PD-L1 expression. So in this case, we're looking at patients with PD-L1 expression greater than 1%. Again, that y-axis here is the percentage of patients with progression-free survival. The x-axis at the bottom, again, is months. And we see the number at risk, which starts out and then drops over time. So again, we go through the same exercise and ask, what's the median progression-free survival in this case? So we come to 50% on the y-axis, draw a line across, and see where it intersects each curve. Now, in this case, the blue line is chemotherapy, which is the standard control arm for this study. And we see that chemo only, patients are surviving about 5.5 months. By contrast, the intervention, the combination of nivolumab plus ipilimumab, we see that patients are surviving roughly 7 months. So again, as I described before, another thing that we see here is there's nice separation of the curves, which again would suggest to us that there is a difference between the two treatments and that one may be beneficial compared to the other. Let's look at a case where that's not the case. So next slide. So here we're looking at a curve where, again, we're looking at time to progression on the vertical axis or the y-axis and time in months at the bottom. We have two curves. You can see your legend there at the bottom left of the graph. The blue line represents standard of care, and the red line indicates pembrolizumab plus standard of care. Now, this is looking at the use of pembro in patients with multiple myeloma. Now, we know pembro is effective for patients with lung cancer, but we have to do the clinical trial to say, does it confer benefit for patients with other types of cancer? And in this case, we might come to a different conclusion. What you can clearly see, first of all, is that the curves are almost on top of each other. There's not that nice separation between them with lots of white space. So that would suggest that, in this case, pembrolizumab is not necessarily better compared to standard of care alone. You also see all those kind of little vertical tick marks on the curves. Again, that represents the censoring that I was talking about earlier. But basically, the key takeaway is that when curves are close together, it means that one treatment's not necessarily better than the other. Next slide, please. So this is your basic cheat sheet for when you're looking at a survival curve or a Kaplan-Meier curve. Read the title. Look for that space between the lines. Are they separated or are they close together? Check the axis to see if survival is what's presented. In one case, we were looking at overall survival. In other cases, we were looking at progression-free survival. Finally, use that line drawing method that I showed you to estimate median survival. So find that 50% mark on your vertical or y-axis, draw your lines across, and then drop it down to your x-axis to see how long patients are surviving. Okay, now we're going to talk about a different type. So forest plots. I know all this can be kind of confusing, and I want this to be informal, and I don't want you to be intimidated. So we talk about you can't see the forest for the trees. Well, hopefully after today, you'll be able to see some of the forest and the trees. But forest plots are basically comparing the survival for two treatments by subgroups. Now, we know that some patients are going to respond better to a treatment, maybe because of their biomarkers. We also know things like age or gender or location, performance status, all those things can influence response to a treatment. Now, another thing that we want to understand before we get into the plot itself is the concept of a hazard ratio. And that's simply a measure of the effect of an intervention on a specific outcome over time. So in this case, we're looking at the combination of nivolumab and ipilimumab on survival over time. So let's look at the chart. What you see in the left-hand column is subgroup. So you see the overall group, and then it's broken out by different categories or subgroups. That's defined by age, by gender, by region, by performance status. And then as we go across, we see two columns, one for the combination of the two drugs that are being studied, and then we see chemotherapy alone. Now, those columns show us the number of patients who are being evaluated in each different category. So as I told you, the hazard ratio is where we start with the forest plot. And that's basically looking at, is there a measurable difference impact of the intervention on the outcome? Now, we define a hazard ratio of 1.0 as, there's no difference between the intervention and kind of the standard treatment. So in this case, we mark that 1.0 with a vertical dashed line, and you can see that here on the graph. Now, points to the left of that vertical 1.0 line indicate that the intervention is superior to the standard treatment. So in this case, we see that in basically all subgroups analyzed, the intervention, the combination of nivolumab and ipilimumab is superior. Now, a couple of caveats. You see that there's a line going through each of those dots, and that's roughly where 95% of the trial participants would fall when looking at the analysis. And so in general, you want to see those lines be tight and be relatively short, because that tells you that the majority of patients are having a similar outcome. But in the case of patients over age 75, here on this graph, you see that that line is pretty long. So that means, from a statistical standpoint, maybe we have less confidence there, but it can also be influenced by other things. So maybe for patients over age 75, there are other underlying issues or comorbidities that impact the outcomes in that case. So you basically want those lines to be very tight, but that's your basic orientation. And we see, a bunch of numbers there in the last column on the right, and that gets more into statistical analysis, which we don't necessarily have the time to delve into fully today. But, we talk about p-values and p-values of being less than 0.05. And this is actually our, hazard ratio, I should say. But we'll get into more statistics maybe at a later date. So with that being said, let's go to the next slide. Next slide, please. Okay. So this is your cheat sheet for forest plots. Again, always read your title, orient yourself to what's being represented. So read your column labels, figure out the comparisons, look to see, again, find that 1.0 vertical line, which tells you there's no distinction between the intervention or the control. Are the dots more to the left, which would say that the intervention works better, or are they more to the right? Check to see the subgroups and what they are. So again, we saw things broken out by age, by gender, by location, so on and so forth. And look to see which subgroups have dots that are outliers, or which ones may have those longer lines going through them. And so, another kind of just thing to be aware of is as you get more subgroups, you're going to have maybe smaller numbers, the more you kind of break out the analysis. So it does increase your risk of maybe false positives or false negatives. And you want to avoid kind of drawing a lot of conclusions by comparing groups to each other. But again, you just want to say it are more of the dots to the left or to the right. Okay, now we're going to switch gears a little bit. Next slide. So I've gone through two types of plots so far, Kaplan-Meier or survival curves and forest plots. In both cases, we were kind of looking at a real world example of the combination of Nivo plus Ipi to say, does it work better? Based on both of those graphs, we would say, it looks like it has a benefit. It looks like it works better. But there's always a caveat to that, and that comes in the form of adverse events. So this is where we're summarizing side effects by type, severity, the number of individuals that are affected. So here, again, read your title. So here we're looking at treatment-related adverse events reported in at least 10% of patients treated with either Nivo plus Ipi, Nivo alone, or chemotherapy. So here we've highlighted in red kind of two different categories. So we're looking first at any serious event. And then we have three columns looking at the combination, the single agent, nivo, or chemotherapy. And what we see is that we see the number of patients, and then we see a percentile in parentheses. So in the case of the combination, it looks like more patients are having serious events compared to chemotherapy alone. Also, then we look below and we see any adverse event leading to discontinuation. That means patients had such a serious event that they can no longer continue on the trial. Now, again, we see that the combination here appears to lead to more of those types of events than the standard of treatment. So you need to look at all these different pieces to make a good determination about whether an intervention is effective and kind of at what cost it may come to patients. So adverse events are important. Next slide. Now, before we delve into the next types of graphs, we need to define RECIST criteria. And that's basically defining a patient's response to drug and looking at the response to lesions for solid tumors over time. So again, we talk about patients having a complete response, which obviously that's what we hope for in all cases. And that's where, of the target lesions that are being followed in a patient, we're not necessarily following every lesion that a patient may have. We have some that we're tracking, that those target lesions completely disappear. That's a complete response. That's absolutely great. In some cases, patients may have what's called a partial response. So that means there's at least a 30% decrease in the sum of the longest diameter of those target lesions. So if we look at how big those lesions are, of the ones we're tracking, they decrease by at least 30%. Sometimes patients will have what's called stable disease. That means their target lesions are changing in size either between the 20% increase or a 30% decrease. And then finally, there's progressive disease. So this is a situation in which a patient's lesions are increasing by more than 20%, or there's the appearance of new lesions. So with that orientation, we're going to start looking at some additional types of graphs. Next slide. So waterfall plots. I would say of all the different types of plots, I am partial to waterfall plots because when they work, they're beautiful. So we're going to geek out, but data can be beautiful. So we're looking at the change in tumor size for individual participants. As I've told you before, graphs give you a lot of information to help orient you. So we can see here, again, on the y-axis on the left, we see percent change between 100% increase and 100% decrease. We also see, Aubrey, if you can advance, again, we see these, and once more, we see these horizontal lines at our plus 20% and minus 30% RECIST criteria marks. And so here we've broken out patients and their tumor size by color. So in the case of the red bars, and each one represents an individual patient, we have progressive disease because it's more than a 20% increase. Then in blue, those bars fall behind, or fall between rather, the 20% increase and the 30% decrease, meaning they have stable disease. Next, we have the black bars, which have more than a 30% decrease, indicating that this is a partial response. And then finally, in green, the home run, complete response, because there's a 100% decrease or disappearance of the target lesions. So with that orientation, let's look at a real world example. Next. So again, this is, looks very kind of intimidating and confusing because there's a lot of things going on, lots of lines and colors and whatnot, but your graph is your friend because it helps you interpret what all that means. So here we're looking at the title, figure 1, maximum percent change in target lesion size of 56 response evaluable subjects in advanced cancers at all dose levels. So again, the y-axis is that 100% increase down to 100% decrease. Now we see our hashed lines representing the plus 20 and minus 30 mark for our RECIST criteria. And then at the bottom, you can see it tells us what all these colors mean. So orange is no previous treatment. one, or blue rather, is one prior TKI. Green is 2 previous TKI treatments, and yellow is 3 or more. We also see that this is broken out by biomarker. So we have on the left side of the graph, patients with an ALK mutation. In the middle, patients with TRK, and on the right, patients with ROS1. Now what we see, and additionally, we also see the legend shows us what the different stars and symbols mean. So there are certain ROS1 mutations or TRK mutations, whether or not a patient was ROS1 by FISH, but not next generation sequencing. So use all the information that's there to understand what's being shown to you. But if we look at patients with ALK, we see that roughly half of them have progressive disease because they're above that 20% increase in size. The rest of them have stable disease because, again, they're between that 20% increase and 30% decrease. If we move over to TRK patients, we see that the majority of them have stable disease, again, because they fall between those two lines. But then we have one that's beginning to show a hint of a partial response, whereas another has a more robust partial response. Now, if we move over to ROS1, that's what we like to see a little bit more. You're going to kind of compare how many lines are going up versus how many are going down. We prefer them going down because that means tumors are decreasing in size. Again, we do see one that has progressive disease, but then we have several that are stable. And we're seeing several nice partial responses in this study. Now, it's important to note that clinical trials will often read out at early stages to decide whether or not it's worth, continuing into from a phase 1 to a phase 2 and so on to later stages. In this case, ALK patients, since they didn't appear to have any benefit, they were not included in the phase 2 of this clinical trial. So, it's important to collect data early and use that to inform decisions and make some judgment calls as trials proceed. So next. So your cheat sheet for Waterfalls, read all the data that's there, read the titles, read your axis, ask yourself, are more bars pointing up or more bars pointing down? Look for that complete response where the bars are at minus 100%. Ask yourself how many lines fall above that 20% dashed line, how many are in the middle between the 20 plus 20 minus 30, and how many fall below that minus 30 mark. Read your legend to understand any color coding, any symbols that may be used, and you'll be well on your way to being able to interpret a waterfall plot. Next. Swimmer plots. So I hope you're staying with me. We were talking about Dory and Finding Nemo, and we're just going to keep swimming. So now this type of plot shows us the duration and type of response for individual participants. Here we don't see a label on the y-axis, so we don't have to necessarily worry about that. But the x-axis shows us treatment duration in months. Now, again, there's lots of colors, there's some symbols. What does it mean? How do I orient myself? Find your legend. That's going to help you. So next, Aubrey. So we see in red here, it tells us what all of our colors mean. So blue is partial response, purple is stable disease, yellow is progressive disease, pink is not evaluable, and gray is not available. There's some additional information. What are the arrowheads and circles? What does all that mean? So Aubrey, next. And next, sorry, there's some animation. So this shows us that the arrowheads indicate a first partial response, closed circles indicate disease progression, and the arrows at the end show you that the patient is still in the study. Next. We see this nice clustering of arrowheads, which indicates a first partial response, and they're kind of all around the 1.5 month point. And this is, again, back to that previous comment I made about kind of looking for that early data kind of before that 2-month readout. That's, where we're trying to make some judgment calls of, is the study worth continuing? So in this case, patients seem to be having, some kind of effect all around the same time. Now, I mentioned that for some patients represented by the closed circles, they have progressive disease. They're no longer continuing on this study. And then for those on with the arrows at the end, they're still on the study. Now, a couple of things, we see some long lines and some short lines. Now, if you'll remember at the very beginning, I told you that patients come into a trial at different time points. So some may sign up, as soon as they can and get on the study at the very beginning, while others may join much later. And we're going to have different amounts of information on those patients according to when they join. So these lines may vary according to that. Now, in the case of the pink and the gray bars where patients are not evaluable or not available, in some cases, if they drop out or we don't have the ability to follow them, we can't use their data really to inform the clinical trial and the things that we're looking at. But this gives you a basic orientation. So next slide. So your cheat sheet for swimmer plots is look to see how long the bars are. So how long is that effect lasting over time? Is complete response listed in the figure legend? And then read that legend again to understand the color coding and the symbols, just as we did before. That helped us know, well, the colors meant, it helped us know who's having a first partial response, so on and so forth. Okay, so we have one more type of plot to go. Next. Spider plots. Now, spiders, I don't like them in general, just as an insect, it's not my favorite. And I have to say that when it comes to graphs, spider plots are maybe not my favorite either. I'm from the South. We have an expression there. We say something is a hot mess. I think these graphs look like a hot mess. It kind of looks like I rolled out of bed and I haven't brushed my hair yet because there's just stuff going everywhere. But what it's trying to show you is change in tumors over time for individual participants. Now, again, as we've been doing each and every time, we want to orient ourselves to the axis and to the figure legend. So on the left, we see change in target lesion diameters from baseline. So what's the change in tumor size over time? So then we also see all of our colors and what they mean. So purple is complete response, pink is partial response, green is stable disease, light blue is progressive disease. Then we also have dark blue, which is not evaluable. The red diamonds indicate first occurrence of a new lesion, and the blue triangles indicate a patient off treatment. We also see that we have our horizontal dashed lines defined by our RECIST criteria at +20 and -30. And so our question here is, how many of these lines are going up and how many of them are coming down? Back to the hair brushing analogy, I would like, to brush my hair for it to be a nice ponytail and everything's going down in one kind of harmonious way, but that's not reality when it comes to cancer clinical trials. So, how many are going up, which means lesions are growing? How many are staying in the middle? How many are coming down, responding? And do we have any complete responses? Next, Aubrey. So again, I pointed out in next, we see that next. We see those two dashed lines, which orient you to the RECIST criteria to say, are the lesions growing? Are they staying stable? Are they disappearing? Next slide. And next. So again, I told you that the red diamonds were first occurrence of a new lesion and the blue triangles are patient off treatment. So that basically shows us that in some cases, you can see where the blue lines are going up, means tumors are growing, maybe patients are having more new lesions there. Whereas in some cases, patients can be quite unstable, their tumors decrease, and we don't see occurrence of new lesions. So that legend, again, is your friend. It's going to tell you what all those different symbols mean. Next. Cheat sheet for spider plot. Look to say how many lines are going above, how many are in the middle, and then ideally, how many are below those dashed horizontal lines. We're looking for that complete response again, which would be lines at -100%, which means all the lesions have disappeared. So read that legend, understand the color coding and the symbols. And next slide. I think that's it for our spider plot. So with that, that's your quick orientation to understanding what all those colors, lines, symbols, and stars may mean. So Janet, I'll hand it back off to you.
Thank you, Amy, for that great presentation. So I just wanted to mention that this webinar was developed as part of the ISLC STARS program. STARS stands for Supportive Training in Research and Science. STARS was collaboratively developed in 2019 with lung cancer advocacy organizations and individual advocates with the goal of training, developing, and nurturing lung cancer patient research advocates, or PRAs, in the science and realities of lung cancer research. You can learn more about STARS by clicking on the link placed in the chat. That's all. So next slide. Funding for this webinar was provided by Amgen, Bristol Myers Squibb, Genentech, and Lilly Oncology. So now, next slide, we will open it up for questions. As a reminder, please type your questions in the Q&A box, and I see several of you have done that already at the bottom of the screen. And we will not be checking the chat or using the raise hand function to find questions. So I'd like to start out with talking with Amy. As you mentioned, some of these slides are very intimidating. And I remember when I was first in an oncology conference as a new advocate, and I have a science background, but not in cancer. And all I remember was seeing all these slides flashing by and having no idea what they were talking about. So how did you feel when you were first encountering these slides, and what did you do to help you get more comfortable with them?
Well, yeah, I mean, the caveat is I'm a scientist, but, like I said, I think a good kind of comparison is, I'm old enough to have lived before the advent of GPS, when we used to, pull out our maps in the cars and, had to figure out what's north, south, east, and west, and, finding latitudes and longitudes. And this is not that different. I can tell a humorous story of when I was in high school reading a map, there was a smudge on it, and my mom was taking me to a camp, and we got very off course. We got lost. So, use your map, use your graph, use all the things that are laid out for you, because it's there to help you. So get your bearings first and foremost, figure out what your axes are, what they're labeled, because I'm in science, as I was coming up as an undergrad and then in grad school, we had specific courses that were semesters long that were designed to do what I just tried to convey in 30 minutes. So, give yourself some grace, and, you're not going to learn it all overnight, but I think we gave you some good tips to get you started. And I would say that, we have GPS for maps now, but we also have wayfinders like Janet Freeman Daily, like the STARS program, that, are very skilled at helping you navigate what all these graphs mean. So there are some incredible modules where you can learn more. And I know that the participants in the STARS program right now are doing just that. They're looking at these RAND modules and delving into graphs and statistics and learning a lot. But this isn't something you can learn in a 30-minute webinar. It's going to take time. So, the more you do it, the easier it will get. So just use the information that's there, draw on your friends that have done it before, take advantage of opportunities like STARS to delve in deeper, and it gets easier. So that's the good news. It does get easier. But I would turn that back on you, Janet. I mean, yeah, you're our favorite rocket scientist, but you're also a cancer patient advocate and a research advocate extraordinaire. So what was it like for you when you were just getting started?
So what was really helpful to me when I first started encountering these graphs is that I had another advocate sitting next to me, and I'd look at them and say, what is that? And they would be start pointing out the little things that I needed to know. And also the other issue is in oncology conferences, when you're first seeing these graphs, they're up on the screen for like 5 seconds, and then they go on to the next. So it was helpful to sit down with some people afterwards and start saying, okay, what sort of things show up on this chart? So I knew what to look for, like the separation of lines in the K&M curves. So once it just started coming with time, the next time I saw it, I recognized that thing. And then I think the one that was really eye-opening for me is when someone finally showed me how to calculate the median survival by dropping that line. It's like, why hasn't anybody ever pointed this out before? So hopefully these that you discussed today will help a lot.
I mean, like I said, we're here for stars, and I have young kids, and they were a fan of the movie Moana, which talks about wayfinders. There are people who are very skilled at navigating and understanding and reading the stars and reading the data. So find those people; they will help you. And as you do this more and more, you'll start to get it. It'll start to make sense. So don't be intimidated. Take heart, give yourself, time, and you'll get there.
So we've had several questions come in, and if you could put back up slide 11, please. There's a lot of questions about censoring and about the number of at risk on the bottom of these slides. So I think it might be useful to mention, why do we censor people, and do they just drop out of the trials? What does all that mean, and how does it affect the data?
Right. If you look here at the bottom, you see number at risk. So that represents the patients who are on the study. So that number, of course, decreases over time, because in this case, we're looking at overall survival. So unfortunately, some people pass away. Some people may have an event occurrence, and some people are simply, unfortunately, lost to follow-up. So in the case of censoring, there are various reasons why that may occur. But in terms of when you're trying to approve a drug for a population, in those cases where something happens, we lost their data, maybe they decide to drop out for some reason, unrelated to the trial, they can be censored. And so that again is indicated in these graphs when we see these little, I'm pointing at my screen like you can see it, but as we see these little tick marks, like in the purple graph, that's a little bit of what's going on. So when those numbers start to decrease, it's that combination again of patients who have passed away or patients who may have dropped out of the trial over time.
And so the reason that down at the bottom, it says the number at risk is 0, but you see that there's still 20% of the patients alive on the purple curve and more on the green. That's because when patients drop out, for instance, the side effects are too tough, or their doctor says, we need to try something else, they're lost to follow up. And if their data is included, it's a problem. So they are not in that number of risk because they're no longer in the trial.
Right.
But we don't have their survival data, so that isn't reflected on the chart, if that makes sense.
Yep, good point.
Let's also clarify what RECIST criteria is. That stands for what?
So we're basically, the way of thinking about it is we're following certain target lesions, and we're looking at how those lesions change in size. So again, it's a way of defining patients, who are responding, who are having partial or complete response versus those stable disease or progressive disease. So that means their lesions are either growing, they're kind of staying the same size, or they're decreasing. And that's done in patients with solid tumors.
So RECIST is a standard that is used around the world for measuring solid tumors. So one of the questions was whether progression is a standard measurement. It is, but it's, if you've got 20 tumors, that's too much for them to track. So they may pick 3 to track.
Yep.
So, it's not always standard in that absolutely every tumor is measured absolutely the same way, but there is a standard criteria.
Or maybe even responding the same way, right? I mean, at least to the ones you're looking at. So that's worth. Yep.
Okay. So let's see. Another question has come in about evaluable patients if you can go to slide 19, please. So does that mean that some patients are excluded from the graph? Let's go to the next waterfall plot. Next slide, please.
The one with the.
Yeah. Is that the one that says where they're excluded? No, it doesn't.
Or were we talking about the swimmer plot where that showed the pink and the green and not evaluable, or?
Well, no, they specifically said the waterfall plot.
Oh, sorry, you did say that.
So remember right back at the beginning when we were showing the timelines.
Yep.
So, yeah.
So patients come into, a study they can enter a study at any point during that open accrual period. So that may mean that some patients, get enrolled right as the study opens, whereas other patients don't sign up or get enrolled until the very end of that open period. So you're going to have different amounts of information on those patients depending on the point at which they entered the trial. So in some cases, we simply may not have enough data depending on when they entered the trial to be evaluable. So that's something just to be aware of, is that, we're going to basically have differing amounts of data in serial time. Again, you saw patient L, patient S, patient N, they all entered at different points. We're going to have different amounts of information, and whether or not that's enough to be evaluable or not will vary.
Let's go to the swimmer plot. I think that's where it showed up. Okay. See, down here at the bottom, those ones that are not blue or purple.
Yep.
They all happen before 2 months. Why is that important?
Well, again, that's, a 2-month mark is kind of important for making those decisions about, is something working enough to continue the study? We might get some of those early readouts to make some decisions, like, are we seeing any kind of signal? But if we don't have 2 months worth of data on patients, then we say we can't really evaluate them in that particular kind of context.
Well, and also in most trials for oncology, the first scans occur at 2 months.
Right. Yep.
So these people haven't been on the trial for 2 months. They haven't had their first scan. So
yeah, they may not know what the impact is for them yet. Yeah.
Yeah. Okay. So let's go to I guess there's one more question here about censoring patients again. So if a patient dies of disease versus some other cause, are the ones that dies of another cause censored? And I think the answer to that is no.
Right. No, they wouldn't be.
On these charts, patients that die of any cause are shown as a death.
Right.
Yeah. Okay. So let's go to the spider plot, that lovely massive lines.
The tangled web.
Yes. Oh, very nice. Very nice.
I think that's what it comes from, right?
It could be.
I don't know. Or does it look like a spider with like a million legs? I'm not sure.
I've always found this to be really hard to follow. But so people are asking, what do the circles mean? Now, if you look up here, there's the legend in the upper right. The colored circles mean different things.
Right.
But to me, the value of a spider plot is that you can see what happens to an individual person.
Yep.
In the main mess, it's really hard to see, but then you start seeing that there's some people that are stable over time. And that doesn't really show up in any of the other charts.
Yep. No, that's a good point. So, I mean, they're all giving you a little bit of a different view or perspective. And, it's using the aggregate of all these different things together that gives you the fullest picture of what's going on. Like we gave the example when we talked about adverse events, if we had just been going on what was shown in the survival curve and the forest plot, we may have concluded that the combination of nivolumab and ipilimumab was great. Patients were surviving better. They seemed to respond across whatever subgroup we were analyzing. But then when we looked at adverse events, we said, oh, but, it comes at a cost. There's patients who are having very serious events as a result. And so, when it gets back to patients and quality of life and all those kinds of things, all of it together really matters.
So there's another question related to spider plots to see if related to patients' recurrence once the drug is stopped. So this doesn't necessarily show you when the drug is stopped, but I think one of the things that's really interesting you can see on a spider plot is these little red diamonds show you when the occurrence, but the patient continues to be stable despite having the occurrence. That's kind of like on some of the targeted therapies like crizotinib. A patient may have progression and you zap it with x-rays and they stay on the drug and do fine.
Yep.
So this also helps you see that, recurrence is not the end of the line.
Yep.
Let's see. People are asking about the margin of error in these graphs. How do you know whether these plots are reliable? How would you answer that?
Well, I think, obviously different ones will show you different things. So when we talked about the forest plots as an example, that's where I was trying to make the point that when we see those lines going through the dots, that we prefer them to be relatively short, because that gives us greater confidence that the majority of patients, the 95% that fall within that range, they're close together. When we see a larger spread, that means, there's something else going on and the data is not as tight. We didn't really have the time to delve into things like p-values here, or, on a lot of graphs, sometimes you'll see what we call error bars. So especially if it's a bar graph, and, one thing I always look for is whether or not those error bars are kind of short and tight versus, ones that are long, which means there's a lot of variability, or in cases where, you're comparing two bars and maybe they look like they're separated, but then the error bars overlap. So, that tells you that maybe there's something else going on. So, not all these graphs are as good at showing some of those kinds of considerations, but I think, that's where you want to kind of look at the totality of what's being shown to you. Like in the waterfall plots, are most of the lines going up, or most of them going down? That gives you greater confidence, I would say, that the effect you're seeing is real versus, it's kind of a mixed bag of things. What would you say, Janet?
Yeah, I think it's really important for several things, to emphasize what Amy mentioned. One, you have to realize that the number of people in a trial makes a difference. When you do a phase 1 trial, you'll see the results, but it might be 15 people in the trial.
Absolutely.
Or maybe 50. When you go to a phase 2, there's more people, and you may see new things showing up that didn't show up in the first one. So as a patient, when I was found to be ROS1 positive, I went and looked at the data for the phase 1 of the ROS1 trial, and it was really good. And I knew the drug had already been approved for being safe for patients with a different type of lung cancer. So I felt fairly good in following that data and thinking this trial was worth it for me. But there are other cases where you just don't have enough data, and you have to decide what your own risk tolerance is.
Yep.
The chart might look good, but it's still early and we really don't know.
Yeah. An example of that is if, Aubrey, you go back to the waterfall plot that had out Trek and ROS1, we see that, when we break it out by advanced one, please, there you go. So you can see here for ALK, we had 18 patients. For Trek, we only had 7. For ROS1, we had 31, which is a better number, and we're starting to see more of an impact there. But your numbers are important, and that's why we talk about, as a clinical trial is starting, and we have that open enrollment period. Enrollment continues until we hit the predetermined number of patients that's required to achieve statistical significance, and we talk about having enough patients to power a study appropriately to make sure that we're gathering enough data to evaluate the question that's being asked. So depending on what's being asked, there are complicated statistical analyses that will tell you how many patients you need to have on a study. And admittedly, that's even beyond me. I mean, that's why there are people who do nothing but biostatistics. And, I'm working on a large study right now related to COVID and lung cancer. And we have a very talented biostatistician at Vanderbilt who's helping us figure out, based on this question that we want to ask, how many patients do we need to answer that question? And so those statistics are really beyond the scope of this particular webinar, but it's a great question. And I would say, patient size is important. The smaller the size, you have to kind of take some things with a grain of salt sometimes and just realize there are limitations.
Well, I regret that we weren't able to get to all the questions, but we're just about out of time. Amy, do you have a brief summary or wrap-up statement you'd like to make?
I just want to say thank you for the opportunity. It's an incredible turnout. I hope this has been a good primer for people. And again, I realize it can be intimidating. It can be scary to see all these graphs, especially, when it's related to something, related to cancer and people's lives. But, find the helpers, take advantage of all those dedicated patient research advocates who are putting on phenomenal programs like this, like STARS, and, wade in. And there are people here to hold your hand and help you, wade into the waters and start learning what all this means. So good luck. I hope this was helpful, and take care.
Well, that's all the time we have. Thank you, Amy, for joining me today. And thank you to everyone in the audience for attending.